Indeed, and I hope you can hear me clearly. I'm speaking from Ho Chi Minh City in Vietnam. It's a pleasure to be here. I'm going to talk, as has been introduced, on the subject of adjunctive corticosteroids for tuberculosis. I will be touching on my favorite topic of TB meningitis, but I'll try to be a little bit broader than that and come to some conclusions as to where we are at the moment as to this topic. Right, so let me just make sure my slides start to move. There we go. So a little bit of history, first of all. So if we look back to the era before the start of treatment, or at least before the start of antimicrobial chemotherapy, treatment was, well, it's summarized in the central picture there, which was lying around in mountainous regions, which were thought to be beneficial for the evolution of the disease. And this is particularly in Davos, but actually in 1940, there were more than 200,000 beds across Europe and the USA administering this type of treatment, and it was beautifully captured in the book The Magic Mountain by Thomas Mann. Nowadays, these hotels and these sanatoria are used for a rather different purpose, particularly in Davos, and this is rather more comfortable seating and a rather different audience in the Davos World Economic Forum a few years ago. So tuberculosis changed enormously in the 1940s when treatment became available. For the first time, at least antimicrobial treatment became available. And these two men here, Selman Waxman on the left and Jorgen Lehmann on the right, were responsible for the first two drugs, and that's streptomycin and para-aminosalicylic acid. And streptomycin always seems to get the headlines as being the first drug, but really they were almost contemporaneous. So you can see here that the report in the Lancet in 1946 by Lehmann describing the first treatment with para-aminosalicylic acid in 1948, streptomycin. But the importance really of them both being discovered at the same time is in the central figure, which I mean, it's obvious to us now, but then when you use monotherapy with streptomycin, it was resistance became very, very easily and rapidly present, as you can see in the graph. So the light grey is a monotherapy with streptomycin, and you've got the proportions of people with resistant cultures over a period of 6 months. And then as soon as you added a second drug, para-aminosalicylic acid, you protected against the evolution of resistance. And of course, we know that well now, but we didn't know it well then. But one thing that was apparent as soon as tuberculosis became a treatable disease with antibiotics was that when you started treatment, you also had attendant inflammation. And sometimes that inflammation was really troubling. And those of you who treat tuberculosis regularly will recognize this phenomena very well, because it's very common. So you start killing bacteria, but the consequence is paradoxical, if you like, inflammation. And you see that in many forms of tuberculosis, if not all forms of tuberculosis. So for example, the chest x-ray I show you here, someone with very profound, extreme and disseminated TB. And this is shortly after the starting of standard 4-drug therapy. And you get a large inflammatory response. And sometimes these people require intubation and mechanical ventilation and become very seriously unwell. Lymph nodes becoming inflamed after the start of treatment, of course, are common too. Often don't require too much treatment, but sometimes, obviously, people think about anti-inflammatory treatment. And the same is true also of the inflammatory complications of brain tuberculosis, which is something I'll talk about later. And of course, before the arrival of HIV, this was a well-described phenomena, but after the arrival, and particularly after the arrival of antiretroviral treatment, the phenomenon of immune reconstitution inflammatory syndrome, or IRIS, also became very well described in the context of TB. And whilst the two have clear differences, they also have a lot of overlaps. I'm not going to have a lot of time to talk about the pathophysiology of these two conditions, but we can think about the shared therapeutic responses to them. So whilst it was recognized as soon as drugs became available, as I just said, that inflammatory complications were common, this is the first report of someone addressing the hypothesis that if you controlled inflammation at the same time as killing bugs, you might get better outcomes. And this was in TB meningitis, a report in the New England Journal of Medicine, 1953. A small case series, seven patients only, but suggesting, obviously very limited data, but suggesting that if you added cortisone in the presence of active anti-TB treatment, you got better outcomes. Hardly definitive evidence, but the first of its type, indicating that in some cases of tuberculosis, if you controlled inflammation at the same time as killing bacteria, you got better outcomes. So the question you can ask, I suppose, initially is, should you be using corticosteroids for all forms of TB, regardless of where the bugs are and the types of disease? Well, this was a question that was addressed in this meta-analysis and review published in 2013 in the Lancet Infectious Diseases. And actually, the results are really quite intriguing. So I just highlight the summary slide, the summary data here, so this is favoring steroids, this is favoring control. So you can see actually that in this meta-analysis, it suggests that there may be a benefit in terms of mortality of giving steroids for all forms of tuberculosis. But the devil is in the detail here, and the numbers are not particularly large. And there's only about, 6,000 patients randomized here, and large numbers of them are in meningitis and pericarditis, which are two diseases we'll come back to, in which you do appear to have a beneficial effect. So it's rather dominated by diseases which are known to benefit from having adjunctive corticosteroids. But nonetheless, an interesting analysis. And they went on to report, and this is a related Cochrane review the following year, just looking at pulmonary TB. So what you can see here is death at the top and sputum conversion at the bottom. And I'm sorry, you can't make out much of the details of the table, but there are a couple of important things to point out for those of you who can't see it very clearly. The first is that nearly all of the data from the trials stops in about 1980, 1985. So these are old data, often before the advent of or the use of rifampicin. Secondly, that you do appear to have a mortality benefit with steroids for pulmonary TB. It's modest, but it appears to be there. But there is no suggestion that there is any impact on 2 months sputum conversion. And I haven't showed you the data, but they also looked at 6 months, and they looked at other outcome measures, and there was no apparent harm, at least, of using corticosteroids for pulmonary TB. Yet it's still not widely used, and probably because there's significant uncertainty and recognition that there may be some people who benefit from steroids, but many don't. But that remains to be defined, exactly who would benefit with pulmonary TB, who would benefit from steroids. You could say, well, it's going to be the people with the most severe and the most disseminated forms of the disease, particularly miliary tuberculosis, but the evidence is really rather lacking. There's only one randomized controlled trial in the Chinese Medical Journal published in 1981, small, 55 adults. Rifampicin wasn't being used, and there was a non-statistically significant improvement in some outcomes with steroids, but this is hardly going to change practice. But this is really all we have. So we lack evidence, I think, particularly for the more severe forms of TB, where tuberculosis outcomes may be improved by controlling the inflammatory response. Plural TB, the evidence is a little better, a little more targeted, but nonetheless, so this is a Cochrane review updated in 2017. Only 6 trials addressing this question, 590 patients, so hardly a large number. Really what these data suggest is that you may get enhanced resolution of symptoms, so people feel better. And there may be a reduction in residual fluid at the end of treatment in the pleural space. But otherwise, there are no beneficial effects on long-term measures of outcome, such as pleural thickening, adhesions, and restrictive disease. So no really good evidence that corticosteroids improves the longer-term outcomes of pleural TB. And this was the first, the trials that were conducted in HIV-infected individuals, relatively small numbers, but it was the first time that there was a signal that you may get increased Kaposi's sarcoma in particular, but malignancy in those HIV-positive individuals treated with corticosteroids. And you can just see there the data from one trial, a couple of hundred patients, and 6 these are all HIV-positive, 6 developed Kaposi's in the Dex arm, whereas none did in the other arm. So that's a signal that we need to look out for, I think, and I'll come back to it in a minute. Pericardial TB, the data are at least a little bit more compelling than pleural TB. So there was 2 very highly cited and nicely done trials conducted by George Strang and others in TransSky, published in 1987 and 1988. They divided pericarditis into effusive, constrictive, and constrictive, and they addressed the management possibilities of effusive and constrictive, randomizing between drainage and prednisolone for effusive disease and prednisolone or nothing for constrictive disease. And they used an 11-week regimen of prednisolone as indicated there. And they published 10-year follow-up, which is very useful, clearly. And you can see the figures there. So these are for survival in both constrictive and effusive pericarditis. And essentially little evidence, or little statistically significant evidence at least, of benefit in terms of survival on constrictive pericarditis, particularly over the long term, but some suggestion that in effusive pericarditis, evidence that corticosteroids improved outcome and survival. And this is the sort of summary figures for that. So it seems that prednisolone, so remember that these are all predominantly HIV uninfected individuals, it reduces the need for drainage, didn't have much of an effect on pericarditis, but overall reduced death. So in general, in HIV uninfected individuals, prednisolone is recommended by most guidelines. There's one trial published in 2014 which adds significantly to these data. This was a factorial design which randomized prednisolone or an unusual non-tuberculous Mycobacterium indicus pranii. And the long and the short of this trial, which was done in HIV-infected individuals, was there was very little evidence of benefit at all. And again, there was a slightly concerning suggestion that there may be more malignancy in the prednisolone-treated patients. So this is an updated meta-analysis published in 2018, which kind of softens recommendations, really, or at least softens the indications for giving corticosteroids. But the conclusions, and I've included them at the bottom there, which is that HIV-negative patients, it may reduce death, but the data for HIV-positive patients is much less compelling and generally is not recommended. So then it comes to TB meningitis, and so this is a disease that those of you who come across it even infrequently will know that inflammatory complications are very, very problematic, particularly the formation of tuberculomas in the brain, which can occur months, sometimes even years after treatment. And it's got a very high mortality, around 25%, and that mortality is stubbornly at that level. It has been at the level for the last 20 years, almost regardless of what's been of any advances in certainly in anti-TB treatment. And the mortality in those who are infected with HIV is probably double that, actually, in many parts of the world. And so the question about whether or not to give corticosteroids is a long-standing one. As I've shown, it dates back to the 1950s and the advent of anti-TB drugs. And these data from the most recent Cochrane review published in 2016 suggest, and you can see that here, I hope you can see my arrow, but you can see that there's a suggestion, at least within the first 24 months of treatment, that there's a beneficial effect on mortality, but that appears to disappear over time. There is no evidence, unfortunately, that corticosteroids, and this is in children and in adults, reduces neurological disability. We haven't got time to go into the reasons why for that, but it appears to be, the benefit appears to be in survival only rather than mortality. And the other question that is often asked is around safety. And again, these drugs, despite plenty of reasons for concern, do appear to be extremely safe, and particularly in gastrointestinal bleeding, for example, which many people may be concerned about. The data really don't suggest that corticosteroids increase gastrointestinal bleeding within the context of TB meningitis. So they appear to be safe with little evidence of harm, at least. If we just go for a little bit more detail on this is the largest trial done, and I apologize for being self-referential, but this was a trial published in 2004, which demonstrated really for the first time in adults that those without HIV infection, certainly, which is the figures on the left, do benefit in terms of survival from dexamethasone. But those with HIV infection, you can see there is very unclear. So it was only 98 patients, so this is small. And actually, to date, there have been no more published data on HIV-infected patients randomized to dexamethasone. We have actually we've completed enrollment of a 520-patient trial. The last patient will complete 1-year follow-up in April this year. So we should have a bit more data probably in next July, August time. So look out for that. But nonetheless, as the Cochrane review showed, if you look at the longer-term outcomes, so this was long-term outcomes over 5 years from that trial. What's intriguing is that you can see that in grade 1 disease, so these are the people who have the least severe forms of TBM, and they come in with a coma score of 15. Actually, their survival benefit, which was great, actually. Many people thought that before we did this trial that we actually shouldn't include grade 1s because they were unlikely to benefit from corticosteroids. But as often the way with research, unsurprising things are found, and actually the effect in grade 1 was bigger than in grade 2 and certainly in grade 3. And what you can see is that effect seemed to be more prolonged over time in grade 1s as opposed to grade 2 and grade 3, where you lost that effect. And one can speculate that the reason you've lost the effect in grade 2 and grade 3 is that you've got people whose lives perhaps were saved by corticosteroids initially, but they were left with profound neurological disability and subsequently died of related but non-tuberculous events later in their life. So the question, though, and this is relevant for TBM, but it's also relevant for the other forms of tuberculosis. Remember, this is, the pathology is common to all, regardless of which organ is being affected in the body. But the question is where and how does dexamethasone save lives? And of course, we now know, as we didn't in 1950, that the effects of corticosteroids are very pleiotropic, and they affect very large numbers of different systems engaged in inflammatory responses. So the possibilities are very broad as to how corticosteroids might improve outcome. But actually, when you come to try and address the question, well, which of these many effects is associated with improved outcome, is really difficult to know. And so, for example, following the TB meningitis trial that we did, we looked at very large numbers of different parameters, both in CSF and outside of the CSF, to see if we could determine whether there was now an anti-inflammatory effect associated with better outcome. And there wasn't. We couldn't find anything at all. We looked at, in a subset of patients, we looked at serial MRIs of brains, asking the question whether there were certain inflammatory complications that were macroscopically evident that were reduced by anti-inflammatory treatment, by dexamethasone. And really what you see here, so sorry, you can't see very clearly, this is in contrast enhancement around the basal meninges. This is infarcts, these are tuberculomas, and this is hydrocephalus. And you can see the suggestion that appears to be a few less infarcts, although it's not statistically significant, but really no effect on tuberculoma formation or resolution, and a possible effect on hydrocephalus. So really rather unsatisfactory as well, with no clear evidence that dexamethasone was doing something profound to the pathology of the disease, at least as it appeared macroscopically. And the only thing really we found, which was very intriguing, and it's well worth remembering this, is that, so when we looked at the variables independently associated with death from this trial, some of them would be very understandable and are associated with the disease. So you died more if you had a Glasgow coma score less than 10. You died more if you had HIV infection. And but one of the things which we noted, and this was a strong association, was that down here, if you had an adverse event requiring alteration in anti-TB treatment dose or regimen, that was also a strong indicator, a predictor of death. And when we looked at those people who developed severe clinical hepatitis, it was reduced in those who had dexamethasone. So it may be that dexamethasone improves outcome in something in TB meningitis simply because it reduces adverse events, and particularly drug-induced liver injury, and just allows you to treat with active TB drugs throughout the duration of the illness. So maybe something as simple as that causes its effect. But we were stuck until, well, up about 5 years, from the publication of the trial, until help came from a rather unusual direction. And that was from two scientists, Lally Ramakrishnan and David Tobin, working on the zebrafish model of TB. And this is a model that uses Mycobacterium marinum, and it uses the embryos of zebrafish to screen for the genes that might be associated with susceptibility and resistance to tuberculosis. And to cut a very long story short, they found a gene which encoded an enzyme called leukotriene A4 hydrolase, which is responsible for the production of pro and anti-inflammatory eicosanoids. And they found that the polymorphisms in this gene appeared to be associated with pro and anti-inflammatory responses to TB. And Lally, in about 2011, got in touch with me and said, can you look at the patients in your steroid trial and see whether there's a difference in outcomes? And first of all, we looked at the patients and we genotyped them, and we found, sure enough, that the homozygotes, so these are those who have either high or low inflammatory responses, did much worse from TBM. And we were able to create a model which subsequently allowed us to ask the question whether this genotype actually determined whether dexamethasone was predictive whether the gene determined whether dexamethasone was going to have a benefit from TBM. And again, this is a subgroup analysis of the trial, but what we found here was very striking. So that those people in this trial who had the CC genotype, and this is the low inflammatory phenotype, they did badly and they didn't do particularly better with steroids. The CT genotypes, so in the middle, were okay, and they had non-significant benefit from steroids. But the TT genotype, and this represents about 15% of the population, have a hyperinflammatory phenotype, and they did much better. And so this was the first time that we perhaps began to get a window on why it was that some people appeared to respond to steroids and some people did not, and what the kind of mechanisms behind the therapeutic action of dexamethasone might be. And we confirmed this result in an independent cohort. This is a much bigger cohort of around 800 patients, all dexamethasone treated. And what you see in the middle here, these are the HIV uninfected, and that red line is the hyperinflammatory T2 genotype, and they were doing much better than the other two genotypes. This gene does not appear to influence HIV-infected individuals. And without going into too much detail, because time is running out, we also found that model with predicting inflammation also by genotype also occurred within the CSF, and you had higher concentrations of pro-inflammatory cytokines according to genotype. So we created, or we can create this kind of model for TBM, which probably has relevance for other forms of TB too, we think, whereby you have a spectrum of inflammatory responses that may be genetically determined, but they're also clearly determined also by HIV infection. And people with HIV infection generally have a dysregulated inflammatory response with much higher concentrations of CSF cytokines, for example, for TBM. And that understanding this dynamic, I hope, will lead to better targeted therapies. I'll just, in the last few minutes, just mention this trial because it's important within the overall context of the question of whether we should be using corticosteroids for TB. And this is in the context of preventing IRIS, something I mentioned at the beginning of the talk, and this is a trial published a couple of years ago in the New England Journal of Medicine, which randomized people with TB associated with tuberculosis at high risk of developing IRIS, so they had CD4 counts of less than 100 and they had just been started on ART within 30 days of TB drugs. And they were given prednisolone, and there was 240 adults enrolled into this trial. Anyone with neurological disease was not included, by the way, so this doesn't tell us anything about neurological TB, but it does show that if you use prednisolone in these high-risk patients, that you prevent the RS occurring. So again, a very useful result. So I think if we just draw back now, we can probably say that there's still very considerable uncertainty as to whether steroids improves outcome from all forms of TB. It has become increasingly clear that there is a spectrum of inflammatory responses between individuals, and that a more intelligent approach is needed than just giving people corticosteroids. And I think Catherine's going to give a talk on more intelligent host-directed therapies next. But clearly, I think understanding where people are, where patients are, and on that inflammatory spectrum is incredibly important. And what will also be incredibly important is determining what types of therapies are going to be effective into the future. So in conclusion, I think we can say that in HIV uninfected adults and children, those with pericarditis and TB meningitis do benefit from corticosteroids. Everyone else, I think, it's very uncertain, and it's still uncertain in HIV uninfected patients whether corticosteroids benefit you, except in preventing IRIS, as I've just shown you. I think it's possible that host genetic variation may be able to be used to identify those who benefit. We're just coming towards the end of a large genotype stratified randomized controlled trial in TB meningitis. I think I would wait for the results of that trial before doing anything within clinical practice. And I think it's very likely overall that host-directed therapies are going to have an important role when we consider how to improve treatment of TB, generally of TB, but also in shortening therapy. I think I will leave it there. I'm very happy to take any questions at whatever time that is designated. Thank you.
Thank you very much for a great talk, Guy. I think we have time for questions. I think, and we have two there. So Catherine Ong is asking, is there any data that shows steroids improve post-TB lung disease, such as lung function?
That's an easy one. No.
Okay.
That's, I mean, but sorry, without being flippant, I think the that's been one of the sort of underlying problems with steroids, is that it seems to have been, its benefits appear to be rather acute. It benefits survival within TB meningitis. It reduces effusions in pericarditis and in pleural disease, but its long-term benefits do not appear to be evident, and that is in the kind of fibrotic complications, and it doesn't appear to affect those.
Okay, thank you. So we have one question from David Lai, who is asking, we see patients who have relapsed fever and clinical deficit in TB meningitis once steroid regimen is stopped. So have you seen that in your study? And can you advise on management approaches?
Yeah, we've seen it a lot, and it's extremely common, David, as you'll know, I think. So it's, I mean, the first thing to say that there is no randomized controlled trial evidence to guide you at all. There's only clinical anecdote and case reports. I think it's clear in both HIV infected and in uninfected individuals that, well, most people would restart a high dose of steroids in that circumstance, and that's certainly what we do. Sometimes you have to restart, and you have to treat for a very long time. Sometimes that's 6 months. And these inflammatory complications can be very persistent and very, very difficult to manage. You have to titrate clinical symptoms against dexamethasone dose. And sometimes they seem to be dexamethasone resistant, and you have to look to other anti-inflammatory agents such as thalidomide or infliximab to control them. I think that the common mistake that people make is that they think that these events occur because of a failure of antimicrobial killing. In general, they never do. They occur because of inflammation and the way to manage them is through better control of the inflammation rather than changing around the TB drugs.